Diagnosing and treating adult ADHD becomes much easier when we apply the principles to real clinical scenarios. In this module, we'll walk through several common primary care presentations and discuss how to approach diagnostic reasoning, treatment planning, and referral decisions in everyday practice. A 38-year-old patient presents with persistent depression and anxiety despite multiple antidepressant trials. They describe chronic procrastination, missed deadlines, disorganization, and difficulty completing tasks dating back to high school. Work performance has declined, and they frequently feel overwhelmed by routine responsibilities. At first glance, this may appear to be treatment-resistant depression alone, but the lifelong history of executive dysfunction raises concern for underlying ADHD. In situations like this, it is important to ask, were symptoms present before adulthood? Did academic or organizational difficulties exist in childhood? Is the inattention chronic rather than episodic? Screening with the ASRS B1.1 screener may help identify the need for further evaluation. If ADHD is confirmed, treating the underlying executive dysfunction may significantly improve both mood and functioning. A 29-year-old patient reports distractibility, impulsivity, emotional reactivity, and inconsistent work performance. They also describe periods of decreased sleep and increased energy lasting several days. This is where careful history becomes critical. ADHD symptoms are typically chronic and lifelong. Bipolar symptoms are episodic and fluctuate over time. Key questions include, are there discrete periods of elevated mood? Is there grandiosity or risky behavior? Do symptoms cycle between depression and activation? If bipolar disorder is suspected, mood stabilization should occur before stimulant treatment is considered. In uncertain cases, psychiatric referral is appropriate. A 21-year-old college student requests stimulant medication during finals week, reporting difficulty focusing and studying. This situation requires careful assessment. Short-term academic stress alone does not equal ADHD. Clinicians should evaluate for lifelong symptoms, childhood impairment, functional impairment across settings, and possible substance misuse or diversion risk. Whenever possible, obtain collateral information and avoid diagnosing ADHD based solely on self-report during periods of acute stress. A 42-year-old patient with past alcohol use disorder reports long-standing inattentiveness, impulsivity, and occupational difficulties. The patient has been sober for 3 years and is functioning well in recovery. In cases like this, ADHD may still be appropriately treated, but clinicians should proceed thoughtfully. Extended-release stimulant formulations or lower misuse risk options, such as lisdexamfetamine, may be preferred. Non-stimulant medications may also be considered depending on clinical risk factors. Structured follow-up and close monitoring are especially important. A 35-year-old patient presents with clear lifelong inattentive symptoms, childhood academic difficulties, stable mood, no substance use history, and functional impairment at work and home. Collateral history confirms long-standing symptoms beginning in childhood. This is often an appropriate case for management within primary care. Many adults with uncomplicated ADHD can be treated successfully in outpatient settings. Adult ADHD care requires careful listening, thoughtful assessment, and attention to functional impairment across the lifespan. The goal is helping patients function more effectively in their work, relationships, and quality of life. With structured evaluation, safe prescribing practices, and appropriate referral when needed, primary care clinicians can play a major role in improving outcomes for adults with ADHD.